6:05, so I think we will start. Lauren, are you ready?
Yes, I am.
Okay, good, thank you. So we have 80 people here now. I'm sure there'll be a few more coming too. I'd like to welcome back those of you who have attended our meetings in the past, and a special welcome to newcomers. For those of you who are not experienced Zoom users, if you wish to see closed captions, there is a button to click on the bottom of the screen. You can move the captions by putting your cursor on the caption box and moving it. If you keep the chat box open, you will avoid the orange chat icon popping up and covering the captions. If you prefer not to see the chat, you can drag and drop it to the side of your screen. Please also keep yourself muted so that we don't hear background noises such as sirens and dogs barking in your house or apartment. We are recording this. When the recording is ready, we will post a YouTube link on our website for others who missed it tonight. I would also like to invite you to join our new and improved Facebook page and to thank Catherine Boughton and Brittany Novinsky for their hard work on it. Many of you probably recently received an email with the link to the website. And stay tuned, there will be more improvements, and a long-awaited Instagram account also will be happening. In addition, I'd like to mention that the State Association of HLAA will be having a conference in Glens Falls, New York, September 16th to 18th, and more information will be forthcoming about that as well. Tonight, we are very fortunate to be able to hear from a distinguished panel of cochlear implant surgeons and audiologists: Maja Svrakic, Sean McMenomey, William Shapiro, and Lisa Manna. Our equally distinguished board member and CI researcher, David Landsberger, will moderate. They will all introduce themselves. When the panel is done, if you want to ask a question, please click on the Reactions tab at the bottom of your screen, then click on Raise Hand. After you've asked your question, please lower your hand. You will need to unmute yourself to speak. And in order to give as many people as possible a chance, we do request that you keep to one minute. When you reach a minute, you will be cut off. If you need to ask a follow-up question, you will be given an additional minute. Okay, thank you, David. You can get things started here, please.
Great. Well, first, hi, I'm David Landsberger. I guess I'm moderating tonight. I am a cochlear implant researcher at NYU, which means I have a great deal of technical knowledge, which may or may not be useful, and almost no useful clinical information. So probably I'm not going to be very useful, and I will defer to the clinicians that are actually with us to know something useful. Shall we go around and introduce ourselves? Dr. Manor, you want to go first?
Sure. Hi, everybody. My name is Lisa Menner. I am a clinical audiologist at LIJ Hearing and Speech Center. I'm a graduate of the Long Island AUD Consortium, made up of St. John's, Adelphi, and Hofstra. Before you get your doctoral degree, you have to do a 4th-year clinical year to get clinical experience. So I was able to do that at LIJ in 2014, and I've been able to stay on, luckily, since then. My clinical caseload right now entails fitting of hearing aids for pediatric and adult populations, diagnostic testing, audiological evaluations for all populations, ABR testing both in our outpatient clinic and in the OR alongside our ENT surgeons. And I work alongside Dr. Svrakic with cochlear implant evaluation and mappings. It's an honor for me to be here tonight, and I look forward to all of your questions.
Dr. Shapiro?
Thank you. I actually started at NYU, the NYU Cochlear Implant Center in the end of 1983. We've done probably 5,000 ears since then. We program all 3 FDA-approved devices. I also have a bit of experience with hearing aid dispensing. And right now, I've been recently appointed as co-director of the implant program with Dr. McMenomey, who I think will introduce himself next.
Welcome, everybody. Pleasure to be here with you all. I'm Sean McMenomey, the name nobody can say. Happy to be with you. As Bill said, I'm the other co-director of the Implant Center here at NYU, and happy and look forward to getting all your questions answered tonight.
And then is Dr. Svrakic here yet? No? Okay. Great. So in preparing for this, as people registered for this meeting, I got a lot of emails with questions, and I hope people will come forward and ask those questions in a moment of actual clinicians. But I got a fair number of questions that were very basic that I think we should probably start with as grounding. Primarily, the questions I'd like to start with are, what is a cochlear implant? How does it work? And how does somebody know when they should get a cochlear implant? Anybody want to attack these questions?
Should I begin? A cochlear implant is typically for patients who cannot benefit from conventional hearing aids. In 1984, you had to be absolutely totally deaf and have absolutely no understanding of speech to be a candidate for a cochlear implant. Times have changed. We've expanded the criteria for patients with moderate to severe hearing losses, and we're even implanting patients what we call single-sided deafness, where one ear is normal and the other ear has a profound loss. So a cochlear implant itself is composed of an internal device and an external device. The surgeon, like Dr. McMenomey or Dr. Svrakic, will implant the internal device in the inner ear, and an audiologist, like Lisa or Bill, will program the external device. There's not brain surgery, it's inner ear surgery. That's an important, I think, point. So a cochlear implant allows hearing impaired patients to hear better. And again, it's for patients who are not getting benefit from conventional amplification like a hearing aid.
So I'd like to point out, as Dr. Shapiro is talking, for those of you who aren't watching all the faces, Dr. Menner is actually showing the examples of the devices, the internal parts and things like this. So you might actually want to keep an eye on her window. She's got some nice toys there to share. Okay.
I can get onto that a little bit.
Please.
So usually, so like Dr. Shapiro said, this is the internal, if you didn't see it before, this is the internal implant. This is what goes inside. This is what you do not see from the outside, okay? And then we have to have an external piece called the cochlear implant processor that sits on the outside of the head. This is the piece that picks up the sound, travels through the cable and coil, and connects to the internal magnet, which then sends the signal to the cochlea. So what I usually do with my patients when they come in is I make sure they know the difference between a hearing aid and a cochlear implant and the limitations of a hearing aid versus an implant. So when a hearing aid is not enough, like Dr. Shapiro just mentioned, an implant can go beyond that and try to assess or fix clarity of speech. A hearing aid, we put the hearing aid on, we make sounds louder, but it's still utilizing the same auditory system with the damaged hair cells from the hearing loss and can send a distorted signal, okay? So a hearing aid, a traditional hearing aid, won't necessarily fix clarity of speech. You can hear sounds, but then clarity might still be difficult to understand speech. So with the cochlear implant, what we're doing now, and I have a diagram, I don't know how well it's gonna come across, if you can see it. This is the cochlea here. Okay, you can see that, thanks David. This is the cochlea. This is where we have our auditory hair cells. Okay, so the hearing aid, when we put the hearing aid on the ear, sound travels through this whole system and stimulates the nerve fibers or the hair cells inside the cochlea and sends it up to the hearing nerve to the brain. If there's significant hearing loss here and we have damage to these hair cells, it's going to send that distorted signal. So what a cochlear implant does that a hearing aid does not, we're sort of taking the place of the damaged hair cells in here by inserting an internal implant. So this is probably very difficult to see, but there is, can you see that? It's circular in shape. That's the electrode array, and that's what gets inserted into the cochlea here. So now instead of using those hair cells that have been damaged, we are stimulating the nerve in a different way, an electrical stimulation. So we can, with that, over time, can understand speech more clearly. This will probably pertain to another question, so I won't go on any further, but it's a process. It's a process, it takes time, and I'm sure we'll touch on that.
Fantastic. So I would like people to raise their virtual hands if you have any questions. The way you do that is at the bottom of the screen, there's a reactions button, and from there you can click on raise hands. So please let us know that you have any questions. I can see we already have our first one. John, would you like to ask?
Yes, my question is clinically, and I've been to an audiologist and they told me I was not a good candidate for a cochlear implant. I've been deaf in one ear since I was about 5 years old, and I'm 66 now. The other ear was pretty good, but then the other ear has gone downhill and functions with a hearing aid. And I was told that if you were deaf in one ear for most of your life, your brain was turned off and the likelihood of having results was pretty poor, like 5 to 10% chance. Any thoughts on that?
Okay, I would just say that it is true that there is a correlation between length of deafness and post-operative performance, right? So the shorter the length of deafness, typically the better the patient does. However, there are patients that are implanted with very long lengths of deafness that do pretty well with a cochlear implant. So there's no absolute in this business. I think if the audiologist and the surgeon does a good job in counseling the patient about expectations, because I think that's what it's about, expectations, then it's perfectly reasonable to implant a patient with a long-lasting hearing loss if they have appropriate expectations. I'm not really commenting on your particular case, but we have implanted patients with long lengths of deafness who get some benefit.
I agree with Bill, absolutely. It's all about the counseling and realistic expectations. There's patients that if you lost hearing suddenly and then you get a cochlear implant, the ear hasn't been deprived of sound for that long. And the brain can kind of pick up and really start to adapt to that new type of signal rather quickly. But then if you have a long-term deafness, maybe our expectation is it's going to give you sound awareness. You can hear sound from this side. You'd be able to understand speech. Maybe that's pushing that expectation a little bit, but being able, for safety reasons, hearing sound from the right side versus the left side, localizing, you can get some benefit from it. It just might be limited. So if you go into it having realistic expectations, that's the key to it.
But
Yeah,
to be specific, we're not speaking about long-term hearing loss, especially if it's been aided. And that's why proper amplification is really crucial, because that makes a big difference.
Thank you.
Okay, thank you. We've got a couple of hands up. The next person, is it Hanan? I don't know how to pronounce that. How do you pronounce your name?
That's correct. You pronounce it pretty close.
Good.
Um,
Pleasure.
Something that Lisa said, I would like clarified. I think if I understood correctly, you said it's a process after the surgery. What is the process? Is it that the brain has to adapt, or is it something else?
That's a very good question. It's exactly that. The brain has never heard this type of sound before. It's an electrical stimulation now that we're sending sound to the brain. So the brain has to learn what this sound means. So the process is, and I tell my patients that once we turn it on the first day, so typically you have the surgery done, you'll have your post-op follow-up with the surgeon, and then once they clear you, everything's healing well, we're going to turn on the implant. So you're not hearing anything from that ear until we actually activate it by putting the external pieces on. So the goal of that first day is just to be able to hear sound. It might sound like beeps or squeaks or just miscellaneous noise. Everybody's different. The goal is just to have a program that you're comfortable listening to consistently. The most important thing is to wear the implant consistently, because over time, the brain starts to learn what the sounds in the environment and sounds of speech are. So just as if you were to get a knee replacement or a hip replacement and do all that physical therapy afterwards to strengthen it, same thing for the ear. We want to do oral rehab or be around speech sounds, or maybe listen to a book on tape and follow along and learn what you're actually hearing. So clarity can be achieved. It just is not like a light switch where we turn it on, you're hearing perfectly. It's not like that. And I feel that a lot of people think that that's what it is. But if you're willing to be determined and put in the work and wear it all the time and do these exercises to help things along, it can really be a wonderful thing.
Yeah, I would just add, Dr. Menon is right. I would just add that it's not a pill. It's true. It's not a light switch. It's not a pill you take. It's a process. So what we typically do at NYU is at the 3-month mark, we do an evaluation. Typically at 3 months, you'll see a significant improvement between pre-op and 3 months. And then we do a 1-year eval. After about 1 year with the postlingually deafened adults, you don't get a major bump up, but you can expect by a year to be really doing very well. That doesn't mean you won't get benefit every day in the beginning, but usually after about a year, it's going to kind of asymptote level off.
Thank you.
So next question from Howard.
Yes, I have. Can you hear me?
Yes, we can hear you.
I have 2 questions. One is the impact on daily living, and 2 has to do with cost. Like for daily living, how does it affect like rain, going through airports, going swimming? That's the daily activity question. And the cost question is it covered by Medicare? Whether or not, what's the expected cost over the course of a year?
Do you want me to answer that? It is a device that's covered by Medicare, but Medicare has often different criteria than the regular insurance companies. So if someone has Medicare, you have to be very careful that the patient meets that criteria, because with Medicare, there's no prior approval. So you can implant someone with normal hearing, not that we're going to do that, and Medicare will reimburse you. But if they come in to look at your charts, it's a problem. So we're very careful about Medicare patients having to meet a certain criteria, but they do, in fact, Medicare does cover cochlear implants. In terms of daily usage, all the devices have accessories that allow it to be waterproof. These devices are more water resistant than typical hearing aids. So you can get caught in the rain. Some people have even taken a shower with an external device, and it's okay. I wouldn't recommend it, but cochlear implants are typically more robust against the environment than hearing aids are. And Lisa, I don't know if you wanted to add something.
Yeah, no, that was basically perfect. Depends on the insurance. Medicare seems to be a little bit more strict on their criteria. So as long as we do this full evaluation and we make sure you meet the criteria, it can be paid for. And the accessories are the biggest thing to make it fully waterproof, where you can go in the water with it, but like Bill said, water resistant. There's accessories. I don't know if you like to exercise with it on. There's extra retention devices that can hold it onto your ear. There's different types of processors. Processor is the external piece that sits on the head. There's different styles. For example, one like this that sits on the ear here and then connects with the magnet to the internal implant. And then there's a different style that just sits solely on the head. A round piece like this sits right here with nothing on the ear. So depending on the company, if you usually get 2 processors to always have a backup. So I have some patients that say, for example, use this in a headband when they're working out, or when they play sports and they want an extra piece on there, they can do that, or bike riding or whatever you're into. But a lot of accessories available: TV streamers, mini mics that help in background noise, a lot of things that are available to help with daily living.
And sorry, and if it's not covered by Medicare, what would the expected cost be over a year? You don't have to answer that. It's okay.
I can try answer that. That's a very, oh, hello. I've been here just watching you from a distance. I'm kidding, but I'm Dr. Svrakic. I'm a neurologist like Dr. McMenomey, except I'm a little further east than where he's at. It really depends. I really wish that healthcare was more straightforward in the US, but it is not. But it's sort of like a hospital will cut you a deal depending on your income. So for example, if you were someone who didn't have any sort of health insurance and said, I want to pay for this implant. I had a patient who came in from a foreign country and said, I want to pay for this implant. I don't know how, but the hospital basically cut them a deal and charged them $12,000 for the implant and the surgery. I'm not sure how that's the case when the implant cost about $30,000, but that's what the hospital did, because I guess they figured that, we as a department bring in more revenue so they can cut them a deal. So it's really, I wish that it was a straightforward answer, but if you're billing through insurance, through private insurance, those bills can rack up for the insurance company, not for you. And somewhere upwards in about $100,000, including both the implant, the surgery, the anesthesia fees, the hospital fees, and then all that post-surgical sort of care. No one that I know has ever spent that amount of money. Basically, you're either going to get some form of sliding scale insurance if you don't happen to have insurance, if you're under 65 and living in this country, or if you're someone who's from a foreign country trying to do that. Having said that, and again, it's very specific situations. Some patients who do have foreign country citizenship, I had a patient from Spain, can actually get cochlear implants slightly cheaper in other countries just because the manufacturer will sell the implants cheaper to those countries. So it's a moving target, honestly. But for anyone living in this country over 65, Medicare is going to cover the bulk of that cost, and for most people, all of the cost.
Great, thank you. Catherine, you're next.
Yeah, I just wanted to go back to the question about a cochlear implant after long-term deafness. I lost my hearing when I was 30, and I did not get a cochlear implant until I was 60. I had no hearing in that ear. I heard with my right ear. And that was in 2009. And since then, unlike everything that is expected, I continue to hear better with my cochlear implant every single year. So I would just say, to people, don't be too negative about it, because if Medicare will pay for it, The surgery is not difficult, and you never know what you're going to get. I wear my cochlear implant every day, and would not be able to hear anywhere near as well as I do with just my hearing aid. So.
And that's perfect. That just goes to show that everybody's outcome is different. I also think it's great to hear from a recipient in the same situation, and we can do that. If you have interest in a cochlear implant and you want to talk to somebody who has received the implant, we have means and representatives at the company that can pair you up with somebody who has a similar situation, maybe the same type of or length of deafness, and just see what they got out of it. Because I can tell you what my patients tell me, but I don't experience it firsthand. So it's something special that somebody else who's gone through it can give to you. And I think that's very important. And so Catherine's experience, it's great. That's very encouraging that you can still make progress even after long-term deafness.
I want to add also, Bill, when you're done, go ahead.
I was just going to ask a question to the panel. Which is the best cochlear implant to get?
The one that works, Bill, the one that works.
There you go.
Go ahead. I wanted to add to Catherine, but basically, to me, cochlear implant is sort of like learning a foreign language, and some people are good at it and some people are not, but really it's learning how to manage a new auditory signal and learning sort of how to process it. The younger you are, it's more likely that you're going to learn a new language sooner and faster, but it also has to do with motivation and sort of exercising what you have. When it comes to the best cochlear implant, I have implanted all implants at LIJ. We implant just the Med-Ls and the cochlear implants and not the advanced bionics, which are the brands that we have in this country. There are other brands. China has their own brand. France has their own brand as well. So just not to get stuck with the fact that it's not like there's one company that's just trying to put themselves in the market. That's been sort of healthy competition. When it comes to which cochlear implant is the best, it depends on the situation. There are some subtleties in the cochlear implant manufacturer that may be better for certain situations than others. But overall, brands-wise, they perform relatively similarly, especially if you're dealing with a center or a surgeon who's been using a certain device for a while. Then they have a lot of experience for that. But it's sort of a conversation between patient, surgeon, and audiologist as far as determining sometimes what the best implant is, although the majority of people will sort of be okay with the standard implant or electrode array from either of the companies. And I don't endorse any of the companies specifically, nor am I paid by any of the companies.
Yeah, I would say that at NYU, we talk to the patients about all three FDA-approved manufacturers. And in patients with normal anatomy, and we know the status of the anatomy because everybody gets a scan preoperatively, either it's a CAT scan or an MRI, but we know the status of the anatomy. In patients with normal anatomy, and that's most patients, they can make the choice of which device they want, which one they feel is going to work best for them. So unless there's a crucial anatomic variant or another reason that I might, as a surgeon, want to put a specific device in, at NYU, we just let the patients choose. We can help them with that choice, and we do, as Dr. Shapiro spends a lot of time counseling, but it's really a choice for them to make.
I would just add that we have a lot of patients around the country that are what we call bimodal. They have a hearing aid on one side and a cochlear implant on the other. There are a lot of patients. And the cochlear implant companies have now gotten into the business of, hey, if you're going to wear X cochlear implant in this ear, maybe you should wear X hearing aid in that ear. So that's a conversation we also have with our patients about what cochlear implant may work best with what hearing aid. And so again, that's a conversation you need to have with patients.
Okay, Sid, would you like to ask a question? Sid, you're muted.
Can I ask a question?
Yes. Oh,
Okay,
sorry. Who was that? Sorry. That was not Sid.
Yeah.
The question is,
Hang on.
Yeah.
Sid's turn. I'm going in the order I have them on my screen.
yeah, so the doctor.
Harold Braden, lower your hand.
Hello?
Oh, sorry. My name is Sandash. I have 2 cochlear implants. And when I asked my surgeon about the particular company, I personally decided for Cochlear because they have an excellent after service program. You can get so much help, and they had regular meeting. You can call anytime. You have so many live people. So personally, I like something that is for after sales service was excellent. And they have biannual meetings. I went to their conferences. So from that perspective, I like Cochlear, although I knew there were other companies, but I think they were nowhere close to Cochlear. Maybe I'm wrong.
Okay. Sid, would you like to ask a question?
Yeah. The question was that when we went to the physician who was ready to do the cochlear implant, he says that my wife is not ready for it because her hearing is still not bad enough to be approved by Medicare. So my question is, what level of hearing has to be there below which they will approve?
Well, I think that the cutoff is a moderate to severe hearing loss, but it also has to do with the patient's understanding of speech. Not more than 60% in the best aided condition, but it doesn't talk about how you can test them. So I don't know how your wife was tested, so it's hard for me to comment.
She was tested by the audiologist, and her hearing is like in one ear is 28, the other ear is 40 for understanding the words. She can hear, but she cannot understand above that.
That sounds pretty low to me, but I can't comment unless I saw the audiogram and the speech perception. But I think you said less than 50% in each ear?
Yes.
With a hearing aid?
Yeah, I mean, no, they test without the hearing aid, isn't it? The hearing loss they are testing.
No, the test is with the hearing aid to see how they do with a hearing aid. And if it's below 50%, she would be a candidate depending on her hearing sensitivity. I assume she
cannot understand the words. She can hear the sound, but she cannot understand the words. As I told you, in one ear is 28, the other ear is 40.
Right, but that you said is without a hearing aid or with a hearing aid?
She's using the hearing aid, so I don't know how they tested. I mean, I'm learning only now to understand the lingo of the hearing, so I don't know.
So Medicare looks at someone's performance with a hearing aid.
Okay.
Thank you. The best aided condition for Medicare. So whether it's 2 hearing aids or the 1 hearing aid, they have to score less than 40% for Medicare. So it's more strict than the private insurances.
Thank you. Thank you.
All right. Carolyn, would you like to ask a question?
Hello, everyone. My name is Carolyn. I was implanted with a cochlear in 2009 at NYU by Dr. Owen. Dr. Shapiro, we had spoken back then. We were discussing going bilateral, and you told me because I never wore a hearing aid in my left ear, and because it wasn't stimulated, that my benefit would be small. So I proceeded to get the implant on my right ear with the revision, because I had that revision surgery. Now my question is, now it's been 12 years, I'm doing very well with my implant and the Cochlear. I have to cancel to Game Changer with the streaming, so I'm understanding much better. So my question is, because my brain is now adapted to the cochlear implant, what would my benefit would be on the left side if I want to go bilateral?
Well, I think the question is one of synergy. In other words, is the small amount of benefit you may get from the left ear significantly improve your overall ability to hear in noise, to localize where sound is coming from? Of course, I don't have your chart in front of me, so I don't know what your discrimination is. Are you saying you don't wear a hearing aid on that side right now?
No, I never
No,
wore a hearing
never
aid
wore a
on that
hearing aid.
side, and it's 57 years.
Yeah,
So
that's a pretty.
my question is,
Yeah,
if I would decide to go bilateral with the experience and the adaptation that I had with my cochlear implant on my right side,
right.
would that make a difference?
Well, 57 years is a very, very long time. The fact that you're stimulated on the right side is not a bad thing because sound crosses over in your brain at some point up there to the left. But I'm not terribly optimistic that you would get much benefit from that left side. But there have been situations. We had a patient who we implanted when she was 20 months old. She had meningitis. She was implanted at 20 months on her left side, getting a lot of benefit. Then she was 32 years old and she had some friend. I never wore a hearing aid on the other side, just did really very well with her cochlear implant. She had a few friends that were getting implanted sequentially on the other side. And she said, well, maybe I should do it. I said, well, I don't know. You're not going to get nearly as much benefit. We went up and back. There was a CT done to look in her ear. We did something called the promontory stimulation. Everything was very positive to get an implant. And she got an implant. And she feels there's more of an ability to hear from all around. Not that her discrimination is nearly as good as it is on the other side, but quite frankly, she feels that she did a good thing. But that may not be for you. But it's possible. Anything's possible is my point.
I was just asking because now I'm doing so well with the implant. And a lot of people say, why don't I go bilateral? But I remember what you had told me 12 years ago. And, and I was just wondering if that had changed, if that would change anything.
It sounds like I was right 12 years ago, so I might as well leave it the way it is.
Carolyn,
okay, thank you.
I agree with Bill 100%. I think it depends on how motivated you are to knowing that you're not going to get speech understanding on that side. And maybe it's just hearing noise in the environment. Knowing that, some people decide, well, it's better than nothing, I'll do it. Or I'm not going to go through all of that just to get that limited benefit. So
well, I don't want any more noise. Noise is usually a problem.
Right.
So I don't think I want any more noise. Okay, thank you.
Okay, Debbie, would you like to ask a question?
Yeah, thank you. I emailed David with my question, said to ask it here, but I want to say thank you for being so fast in your response and also sending me an article. I was implanted in October and activated in November, and I have for the last 6 years had chronic migraines, which is about 27 days a month, and was being treated with injections of Ajovy, which were working. And then when I was activated, I started getting bad migraines again. So I saw some research that came out of University of California, San Francisco. It's a small pilot study about an association between increased headache with activation of an implant. It was the only article I saw, and David sent me one that where a study was done where it showed there was no effect. But he suggested I ask the other people on the panel if you've heard anything about other research that might show an association between migraines and implant activation. So that's my question.
Hi, I have done a lot of implants, and I've not really seen that as a correlation. I'm not familiar with the UCSF paper, how many patients it involved or anything like that, but I don't think we really see a correlation with activation and onset of migraines. I think stress certainly can impact migraines, and there's a lot of stress with surgery, and there's a lot of stress with anxiety maybe around activation. So there may be some indirect causes, but I don't think there's a direct neurological correlation between activation and a migraine.
Thank you.
This is right. I'm not an expert. I haven't done any implants, unlike Dr. McMenomey, but what he says is completely consistent with my experience and impression. Anyway, Ruth, would you like to ask a question?
I have a comment rather than a question.
Okay.
I'm Ruth Bernstein, and I had my Med-El implant 2.5 years ago at Columbia. The thing that helped me a lot that no one has talked about is auditory training. I went to the Center for Hearing and Communication weekly for quite a long time. And I think that one of the doctors mentioned this being a new language. And that's part of the auditory training, helps you deal with this new language.
I think actually Dr. Menner actually talked about that at the beginning, and she's right. Oral rehab, auditory training is really very important. We always do it in children, and now we always do it in adults as well. We think it's very helpful. So yeah, I think that may have been touched on earlier, but yes, I agree. You're absolutely right.
Jerry, would you like to ask a question?
Yes, thank you, David. I'd like to make 2 comments based on my experience and ask the panel to comment about them. The first is with regard to when one is accepted as a candidate for a cochlear implant. In my experience, I was first told I was not a candidate by one university-affiliated clinic. And then my audiologist told me to go get evaluated at NYU. And so I did. And to my pleasant surprise, I was told, no, indeed, you do qualify. That was back when I got my first cochlear implant in 2012. Which brings me to my second issue, which is getting new cochlear processors. As you know, I had my second cochlear implant just about a year ago now, and it was wonderful that the NYU clinic was able to not only give me the cochlear processor, the latest model for that ear, but also a matching processor for the other ear. But my point is it true, is it not true that after 5 years, Medicare will cover the cost of a replacement processor? Those are my 2 questions.
I don't remember your first one, but your second one, Medicare will cover an upgrade after 5 years. That is correct, an upgrade. And I would just comment on the first thing you said, which is you were maybe turned down at another center, but we implanted you. And different centers have different criteria for selection, right? There are some centers that maybe aren't, and I'm not saying that has to do with anyone on this panel, but around the country, some centers may not have the experience and they may stick more to the letter of the law. When it comes to someone being a candidate, we're involved in a lot of clinical trials, for instance. So we've been doing single-sided deafness for a long time, where a lot of centers weren't doing single-sided deafness. So if you went to a center somewhere else, maybe you wouldn't have gotten a device if one ear was normal and one ear wasn't. So there are centers that have different criteria for selection.
Great. Cheryl, have you got a question?
Yes, going back to hearing aids, I have 2 cochlear implants. First one I got 2 years ago, the second one this past January, but I had some residual hearing. And so I also have a hearing aid, an EAS, and I haven't heard anyone talk about the benefits of a hearing aid along with the cochlear implant. Could you make some comments on that, please?
So Cheryl, that's great that you brought that up. Thank you. So some people, depending on your hearing loss, can benefit from some acoustic stimulation from a hearing aid, utilizing some of those hair cells in the cochlea that have been preserved and working well, and then also have an electric stimulation to reach the area where a hearing aid would not provide enough benefit. So with those two together, most likely, when you think about hearing loss, we think about there's low frequency sounds and there's high frequency sounds. A lot of those high frequency sounds are the S sound, the sh sound, all important sounds of speech that a traditional hearing aid can't really get to a level that we need to be sufficient in order to hear and understand. So the electrical part of the implant can take care of that. And if there's any residual hearing left over after the surgery, it's great if we can kind of then use a hearing aid component to take advantage of the language or the sound that the ear is used to knowing. And with those two combined, can hopefully give us the best access to sound and to speech.
Yes, thank you. But unfortunately, on the left ear, the first year I had done, after 2 years, I lost that residual hearing. I'm hoping now that the right side, I'll keep it.
Yeah.
Because it does make everything a little bit clearer.
And the good thing, about that though, if it were to change, like you said, we can easily just then address those sounds with an electric stimulation. It's not that we're losing any sound. We just change the programming to use, what we need to use and just take away that acoustic component.
I agree 100% with what Lisa's saying. I would just add that we know from studies that have been around this country that if a patient loses their low frequency hearing and is all electric, they tend to still do much better with a cochlear implant than they would do without it. So of course we worry about losing what we have, but we try to counsel the patients that it's possible you may lose your hearing, but even if you do, you will get significant benefit from a cochlear implant.
Thank you.
I always think that this concern about losing hearing, isn't that one of the reasons we tend to implant the worse ear so that we aren't risking the better ear? We leave the better ear untouched by default usually. So then there wouldn't be any risk involved, at least for that ear.
That's actually a good point too. I had actually a parent come in with their daughter, and they were under the assumption that if we did an implant on one side, it would affect her hearing in both ears, that she wouldn't be able to hear anything until we activate it in both ears. What David's saying is right. We want to implant the poor ear as long as it's medically a candidate anatomically, because we don't want to take away information. We want to give back as much as we can. So if one ear is doing okay with a hearing aid, we want to keep that hearing aid on that ear and address the poorer ear with a cochlear implant. And hopefully the two together gives us the best means of hearing.
I would ask the surgeons about how they do a hearing preservation surgery. So if you have a patient with some low frequency hearing, is there something you do to try to make sure they don't lose their hearing? Is there a way to do that?
I think it's a good point, Bill. I think
Yeah, go
that,
ahead.
you know, every surgery is an attempted hearing preservation surgery. And it's all about being delicate with the tissues of the inner ear. Doesn't mean we can preserve hearing every time. It means that we do a delicate operation every time in the hopes of preserving the structure of the cochlea. But hearing preservation is not always possible, but the operation to do it the right way, it is always possible, and we do it every time.
Yeah, I would say what Dr. McMenomey says. Well, you want to preserve hearing by doing a gentle surgery, and you do that by minimizing drilling or any kind of manipulation of the cochlea. And also you have a choice of electrodes that are minimally traumatic to the cochlea. So even in the case when it's not a hearing preservation surgery, I think most of us who have done this, you know, try and preserve whatever there is, or minimize trauma, just in order to gain that benefit of the auditory hearing. Now, we can't promise this to a patient, but we certainly hold ourselves responsible to the highest quality of surgery.
Eric, would you like to ask a question?
Yes, I have a question. What impact does CI have on tinnitus?
Good question. I would say, and Bill, if you agree, I think there's very different outcomes. Some people tell me their tinnitus is helped greatly by it because it's more stimulation, they're hearing more sound. Sometimes it's unchanged. Sometimes it's worse. I think it's not predictable how it's going to affect tinnitus. I don't know if your experience, Dr. Shapiro, is different.
Well, actually, yeah, what you said is correct. It's interesting because single-sided deafness, I keep getting back to that, where someone has absolutely normal hearing in one ear and needs a cochlear implant in the other, started in Europe before it started in the USA. And they started doing it as a treatment for tinnitus suppression. So these patients had sudden idiopathic, no one knows why, hearing loss, and they implanted these patients because they were complaining of tinnitus, not because they wanted to hear better. Obviously, the secondary benefit, or maybe the primary benefit, was they were hearing better, but it was for tinnitus suppression.
Thank you.
I need to give credit. Sorry, I just want to point out. Sorry, I just want to point out that work Bill was talking about in Europe with the tinnitus suppression for the single-sided deafness was done by my wife, who's somewhere in the background listening in. So
that was a softball.
Yeah. Right,
Yeah,
so,
I wanted to say I've had nothing but positive experiences with patients who have a tinnitus problem because of the hearing loss, and when they get implanted, that significantly improves, especially while the processor is on. There's one thing that I feel like we may not be discussing here, and perhaps it's not the right patient population, but certain disorders such as Meniere's disease, which can cause sort of a progressive hearing loss of both ears in addition to vertigo, also comes with this tinnitus that sort of occurs with attacks. And unfortunately for that very rare disorder, a cochlear implant is not going to do much for that tinnitus that sort of signals an attack. Luckily, most of the time when we do surgery for cochlear implants for patients with Meniere's disease, by then their vertigo attacks are sort of much less severe and happen much less frequently, including the tinnitus. But tinnitus from disorders such as Meniere's disease versus tinnitus from sensory neural hearing loss that was sudden or the idiopathic kind may be slightly different, and cochlear implants affect those differently.
Thank you. Richard, would you like to ask a question?
Yes, thank you. I was implanted and activated in the summer of 2019, and I went regular appointments with my audiologist. We got up about to MAP 20, and we considered that was probably as far as I needed to go. And then COVID hit, and I haven't been seeing her since then, but every time I showed up, she said she was updating the software on my processor. Am I missing out on something by not getting updates on my processor since 2020?
I would say there are always small fixes in the firmware when you see the audiologist. That's what's happening, but I don't think you're missing out on anything. You know, the thing that you might be missing out on is you haven't been programmed in a while. And, you know, the electrode array is in fluid, right? The electrode array is in your cochlea, and it's bathed in fluid, and that fluid has electrolytes in it, which is representative of the chemicals in your body. And that's why with cochlear implants, you need to be programmed a little bit more often than you would be to be programmed if you had a hearing aid. And we see that pharmacological changes and biological changes change the way we hear. That happens all the time. Patients on HGH, human growth hormones, need to be mapped more often. Things happen. Medication changes maps. So I would just suggest, if you think you're hearing okay, great, but probably getting mapped at least once a year is a good idea.
Okay, this is something the audiologist could adjust if necessary.
Well, yeah, that's right.
Okay, thank you.
Dana, have you got a question?
Yes, hi, this is Dana. Yes, well, mine is more about whether it's better to get an implant both ears right away, not both at the same time, because you really need your hearing in the other ear when you're adjusting to the first one. But I have bilateral. One ear is better than the other. But the first ear that I got done by Cochlear Americas back in 2003, I was my worser ear, and it does wonderfully. I'm like in the 90-something percentile, I think like above 95 in hearing. Can everyone hear me, by the way? If I should speak louder, let me know. And this was a miracle. I have a condition called Usher syndrome. So I did have hearing, but it was below 60% word recognition, and a listening system wasn't helping me. But I was a librarian at an information desk, and I had to have people start spelling everything. Once I got my cochlear implant, in 3 weeks, I was dramatically improved. I could hear everyone, and I mean, it was a miracle. I got my second one 3 years later. It was not as good, but still I can hear birds and the microwave, my thermometer, all kinds of sounds. Even though the second ear is not as good, it really helps. So I don't know about all these people having trouble, but now my second ear was my better ear, but it does worse with the cochlear implant. So I'm just wondering if I had gotten them both closer together, it might have worked better.
It's hard to say. I don't think we can really predict that. The only thing we do know is that the longer an ear goes without hearing, there's auditory deprivation there, and it's harder to have that sound, back and understandable. So for instance, everybody's individual case is different. For example, we have pediatric patients who are born deaf both ears, and we do simultaneous implants because we're not losing anything from the other side. I think it depends on how much benefit you're getting from one ear versus the other, because like you said, I think it's very important. You need that other ear with the hearing aid to rely on while your brain is learning this new language and getting up, learning how to interpret the implant. Once we know you're doing very well with the implant, then we usually can go for the other side, maybe 6 months or so, but everybody's time frame is different. Everybody's case is different. It's really hard to predict or to say if the outcome would have been different, I think.
So what this leads me to believe is there may be a better ear and a worse ear to begin with, that with the cochlear implant. So it's the luck of the draw, which ear you pick. But in my case, I had a moderate hearing loss as a child. And by the time I was in my 20s, I was profound severe. And then I got my implant in my 40s. And still, it worked very well. So I advise anyone who needs a cochlear implant to definitely talk to as many people who've had cochlear implants, get their experience, and visit an audiologist at a cochlear implant center and really at least find out if you're a candidate.
Yeah, Dan, I think you're right. You're right on point right there. And we've talked a lot about percentages on hearing tests, but really the bottom line is if you're a patient with bilateral hearing loss and you're struggling with well-fit, appropriate hearing aids, then I agree, get into a center and get evaluated. If you're not a candidate, that's still not a waste of time, because now we have a baseline exam to look at going forward. So I totally agree with you, Dana.
Yeah, thanks. And say hello to Bill Shapiro. I remember many years ago, we had an understanding hearing loss presentation at the New York Public Library. So.
Have I been around for many years?
Yes.
All right, Howard, have you got a question? Howard?
Sorry, yeah, sorry, I had on mute. Yeah,
No problem.
So I'm 75 years old. I started having hearing loss about 6 years ago. About 3 years ago, got so bad that severe in one ear. My other ear is relatively fine. My inclination is to wait longer, because I assume technology is always improving and things are getting better. So my real question is, is there any like future ideas on how to deal with hearing loss? And out of curiosity, how come they go through the skull and not through the ear itself?
Well, you just said something very important, which we talk about all the time. When you're a candidate for a cochlear implant, and you should get a cochlear implant, never wait for new technology to come out if you're a candidate. So I can't comment on whether you're a candidate or not. It sounds like one ear is doing okay. And so therefore, if you have Medicare, you might not be a candidate, I don't know. But never wait to get an implant if you're a candidate. Don't do it tomorrow if you're a candidate today. Because as we said early on, there's a major correlation, a high correlation between length of hearing loss and performance with a cochlear implant. So, yeah.
And I think it's really important for the general public to understand this, because I'm sure we've all experienced kids, young adults, and their parents sort of saying, well, I don't want to, do a cochlear implant on the other ear, even though it's a candidate, because I'm going to wait for other technologies. And we really have to understand there may be future technologies, and sure, there's some cutting edge research, And I actually do a conference of the future of implantable auditory devices in New York. So for every time for that conference, I sort of prepared to see, well, what do we have what's available? And really nothing in any foreseeable future. And I don't want to be pessimistic about that because there is some valid research that's going on. But unfortunately, not in your lifetime. The 70-some-year-old gentleman that just asked a question. So don't wait. And I would certainly say that to parents. And I've seen moms who told me, oh, my son got an implant when he was a baby. And they said, let's not implant the other ear and wait for technologies. And the kid's 25 now. And that ear, is going to get a minimal benefit from an implant now. And I honestly think it's really important that we're extremely straightforward with the public to tell them that this is really, yes, there may be some cutting edge research. And how many times have people told me, oh, there's chickens and their hair cells are growing, and those are chickens, they're not people. And I really think that, as Bill said, if you're a cochlear implant today, get the implant today. If you're not, then you have time. But if you are, then no point in waiting. You're just going to do harm.
I feel
And the other thing that you said was about the surgery itself, and I think that that's worthy of at least a little bit of discussion. The surgery, modern day cochlear implant surgery, is a very well refined, very thought out, straightforward procedure in 99% of the patients. It's day surgery, takes about an hour, go home the same day. The incision is very small, maybe 1.5 inches, 2 inches behind the ear. We don't shave the head. It's a very straightforward process. And so we go through the mastoid, which is behind the ear. We don't really go through the skull. That's kind of a scary terminology for patients to hear. But this is a very different surgery than it was when I started 25, 30 years ago, where patients endured 5 hours of surgery and stayed in the hospital a week. That's not modern day cochlear implant surgery.
I feel like it's my duty to reiterate what everybody else has said on this important point. There's no doubt the cochlear implants that are on the market today are better than the ones that were on the market 15 years ago. Having said that, the differences in the technology are very small compared to the differences that you would experience for having waited those 15 years. So waiting to see what comes down the pipeline seems like a very unwise idea. Okay, Deborah, have you got a question for us?
I'm shaking my head here because I did drag my feet a little bit, and I was afraid of surgery. I'd never been under the knife before, so to speak, and had it done in November of 2020. I celebrated my year anniversary just recently. It was turned on 2 weeks later, and I remember it almost makes me cry because I was driving home and I was talking to myself, and I could hear myself talk because I have one side was where I got it implanted was totally deaf, and this side is next to nothing. And I was just going, mama. I was making all those consonant sounds that I was unable to make, and therefore unable to understand speech. And I kept talking to my little voice, as if it was a separate person. Now I see a phone thing. I don't know if that's interrupting what I'm saying, but anyway, it's given me my life back. Even though I was doing very well, trying to do talk to text and having people interpret for me at dinner parties because I really didn't hear anything. All of a sudden, I'm fully engaged in life. Somebody walks by me in the park, and says hello as they're passing. I can say hello back. It's amazing. The one thing that, and I reached out to you, David, about this, the only thing that isn't good is music. I thought that my perception was true pitch, but it's not. And that I would love to explore more, because I know, David, you're doing a lot of research on that and so on. But I wouldn't give this up because I couldn't hear anything before, let alone music. It's still all in my spirit and in my memory, so that's okay. But do not hesitate. It's life-changing. You may not understand as quickly as I did. I feel very lucky, but it's unbelievable, really. So thanks.
Great. Thank you so much. I am indeed doing music research. So if there are any cochlear implant users out there who are interested in participating in music research, please let me know. Michael,
Yes,
do you have a question?
yes, I hope this is okay. It's not a cochlear implant question, but something that was raised about oral rehabilitation. I've worn two hearing aids for 12 to 15 years. I really don't hear much. But 6 years ago, I had a stroke. And after that, my cognition plummeted. I really don't understand anything people say. And I do some speech reading. But when I talked to the hearing center about other auditory rehab, they said there really isn't anything but speech reading. Can you advise me on that a little bit?
Lisa, do you want to take this one, or we can double team this one?
Sorry, I was muted. Yeah, I guess auditory training is really just stimulating the implant and letting the brain make associations with what you're hearing. There's a lot of apps now, which is really great, that work with, for example, there's one company that has Telephone with Confidence, and you can listen to a telephone passage, but also read along at the same time. So it's training the brain that way. I don't know if this is really answering your question, but Bill, if you want to take over.
Yeah, I was just going to say that I think we as a team, and I'm sure Lisa feels the same way, auditory training is critical. It's critical for hearing aids, and it's critical for cochlear implants. So much so that we are asked, when we see patients in the in our clinic, not at the Cochlear Implant Center, but at our clinic, we're handing them a flyer to tell them that they should have a package of oral rehab and see our speech therapist. Now, there's nothing wrong with their speech, but here our speech therapist does auditory training, seeing where you're having trouble hearing, what sounds are you having trouble with. And we really do think that's critical. So I'm sorry to hear about what you're saying to me, because we think oral rehab is a very important component, but not just cochlear implants, but hearing aids as well.
Right.
Ruth, we got a question for us.
I want to make a comment again. I was 85 years old when I had my implant. So I just want everybody to know that if you're in good health, there is absolutely no reason why you should not have an implant. So just a small comment on it, because that question comes up often. Am I too old?
Thank you, Ruth.
Ruth, I can tell you that it's kind of amazing. As an otologist, neurotologist, by far the happiest part of my practice is cochlear implants. And in my own experience, the youngest inpatient that I have implanted is 5 months old, and the oldest was 97. So that's quite an age range there. And we don't turn people away based on age. We do these under general. These can even be done under local anesthesia here. So we don't turn people away based on age.
I see Michelle Frisbee has had a hand up.
Yes, she is next. Michelle.
Sorry.
Hello, sorry. I'll put my picture on here. Thank you for opening this up across the country. I'm joining you from Wisconsin, and I am a bilateral cochlear implant wearer, Cochlear America's brand. I got my first implant 20 some years ago and my second one just 5 years ago. So my question is just wanting to expand a bit more specifically about the conversation we were just having in relating to oral rehab or auditory training for that second implant, or when you're not having as good of results as you'd like to have. So in my case, I did really, really good on my first implant because I got it implanted pretty quickly after I was losing hearing in that first year. But then the second one, I waited and did not get for 15 years. So that ear went unaided for quite some time. And I'm one of those candidates who did not do as well with their second one as they did their first one. So not to dwell on all that, but to be more specific, could any of you recommend more? I know we all know that auditory training is important, but how and what types of things? I keep hearing about, listening to podcasts, and I know there's a number of apps out there, but I really do not do well with that one side. And everybody is telling me, okay, you need to take the good side off and let the bad side work more. So I'd like to hear your opinion on that, first of all. And then how, if I don't hear very good on the new side, and if I'm not going to hear what they're trying to, like do the apps and the testing or whatever, is there certain apps or specific ways that I can try to train that side to hear if it's not hearing well enough for me to be reactive on some of these apps or tests?
Michelle, I think, so some of these apps, they have different levels. I'm not sure what brand of cochlear implants you have, but what you're able to do on one side, might not be able to do right now with the other. So just something as simple as telling if two sounds are the same or different. It might just be, it's just building blocks. So there's one particular exercise that you stream. So yes, I agree that if you're streaming the signal to your implants, maybe only stream to the one ear you're working on, because the other ear is definitely going to help that. So you designate time during the day that I'm going to use this for training. I'm going to just stream to the ear that I'm having more trouble with, and start with very basic. So there's this one app that will say 2 words, and you just have to say, was it the same or was it different? You don't have to understand the word. You just have to know if it's the same or different. That's very, very basic. And then as you go through it, it gets increasingly harder. So I think don't jump right into listening to a book on tape and something very advanced like that. Just very simple, maybe telling syllables, number of syllables, or word sounds different or the same, very basic, and building your way up.
I do have the Cochlear devices N7s, which I did just get an upgrade and am streaming to my iPhone or compatible, So are you able to tell me what that specific app is?
So actually there's an app specific for Cochlear called the Cochlear Co-Pilot.
Okay, yep, I've heard of that one. Is that the one you were just talking about with just
talking about
a couple sounds?
Practice exercises. Yep, you can start from, it says listening basics, and it might just be same or different up until you're able to listen to a conversation and answer questions about it. But I think you have to start, very, very basic and get through those steps first, like building blocks for that side.
Okay, good. Thank you.
I think what Lisa said was perfect. How long do you take your better ear off and work with your poorer ear? How often does that happen?
Not enough. I know, and that's what's hard. I know I need to do it more. It's just like everything in life. We know we should drink more water, eat less dairy, eat less red meat, do all these things in life, get more exercise, and it's just a matter of making the time to practice. I know.
Right. When you're in a mellow situation, if that ever occurs when you're home, you can take that good ear off for an hour or two. Not when you really need to do your best listening, but when you're home and you're mellow and maybe watching TV or talking to a family member. I think that's a good idea. I think you're supposed to drink more wine, not more water.
There you go. Yeah, they say 1 glass of red wine is good for you, right? Every day.
2 must be better.
No, I appreciate that. Thank you. I know I'm trying. I'm trying to think about more specific ways to do that, because I really rely on that good side, because even like watching TV, I do have captions, and I do, stream, try to listen to even music, and I'm trying some podcasts. But the bad ear is just so bad that I really don't understand much yet. So I'm trying to find ways that I can just take those baby steps.
I have some patients that, and what Bill said is so important, don't do this in a high stress situation that you need to hear everything that's going on. You don't want to do that. You want to designate a time. Maybe it's over breakfast in the morning. I'm going to take off my better hearing ear, and just something that you don't have to catch every word, and it's going to be okay, just to focus on utilizing that poor ear over just a time where it's calm and you don't have to know everything that's happening.
Right. Okay. Thank you.
David?
Yep.
David, we're about out of
Huh.
time, and I think Michelle was the last question.
Yes,
So
that's right.
just a few closing comments. One comment I do have about someone earlier described the surgery as being easy, and that's absolutely true from the patient's point of view. I'm sure that from the surgeon's point of view, it's a very complicated operation, and you want to get the best surgeon you can. Having said that, a lot of the success you will have will depend on the audiologist. You will, once you're done with the surgery, you will go back to the audiologist 5-6 times for mapping and various tweaking of the maps. And you really need to have someone that you're comfortable with. And you also need to be able to assert yourself with that audiologist to tell them what problems you're having, and to think about the situations in which you're having those problems. That's the only way they'll be able to help you. But I would like to thank Maya, Sean, Lisa, and Bill, and David. This was a terrifically informative presentation and discussion. And as always, I'd like to thank our captioner, Lauren Schechter. We continue to see many new faces tonight. To learn more about HLAA, to join, or to donate to help us continue our activities, please go to the chapter website, hearinglossnyc.org. We will be having elections to the board at our May 17th board meeting. If you're interested in applying, please email us at info@hearinglossnyc.org. We're also beginning to think about next year's programs, and if you have ideas you'd like us to consider, please email us about those as well. On May 3rd, the topic for our meeting will be a new generation of audiologists. Dr. Barbara Weinstein, professor and founding executive officer of the Doctor of Audiology program at the CUNY Graduate Center, will talk with Alexis Lederman, a third-year doctoral student at CUNY, and Dr. Sophie Racine, who received her Doctor of Audiology degree from CUNY after completing her audiology residence in Montefiore Medical Center. They'll discuss why they chose audiology as a profession and their interest in treating younger adults as part of their future practices. I hope to see all of you then, and if you know some younger people who would be interested, please tell them about this meeting. So again, thanks to all and good night.
Thank you.
Thank you, everyone.
Thank you.
Bye.
Right.
Thank you. Bye, everyone.